right, welcome to the Explainer. Now, if you're a vascular trainee gearing up for your FRCS exams, you're in exactly the right place. Today, we're going to do a deep dive into one of the most important papers you need to know inside and out, the BASIL 1 trial. Let's get you absolutely rock solid for that Viva. So, picture this. You've got a patient in front of you, they've got severe limb ischemia. Their leg is literally on the line. And you've got two main tools in your toolbox to get the blood flowing again: a big bypass operation or a less invasive balloon angioplasty. For decades, this was probably one of the biggest arguments in any vascular unit. And here's the kicker. The choice between the two? It basically came down to opinion, who trained you, what your local unit preferred, but there was no real hard evidence. You had surgeons banging the drum for durability, and the radiologists rightly pointing out that their way was safer and less invasive. We were missing what we needed most: level 1 evidence. That is, until the BASIL trial dropped in The Lancet back in 2005. So to really get why this trial was such a game changer, let's just rewind and look at the clinical problem everyone was wrestling with. Okay, so we're talking about severe limb ischemia, SLI. And let's be clear, this isn't just a bit of cramp when you walk. We're talking about that awful nonstop pain at night. Or even worse, tissue that's dying. Ulcers, gangrene. It's a huge red flag that the limb is dying. And if you don't do something, that patient is looking at a major amputation and, frankly, a terrible prognosis. So what were the two sides of the coin here? Well, the surgery camp, they were all about durability. A good vein bypass, they argued, could last for years and years. But that came at a cost, right? A big operation meant a big initial hit. Higher risks, more complications, and a much bigger bill. Then you had the angioplasty advocates. They'd highlight the lower risks, how much cheaper it was, and the shorter hospital stay. But the big question hanging over it was always, how long will it last? So to finally settle this argument once and for all, the bypass versus angioplasty in severe ischemia of the leg trial, yep, that's BASIL, was designed. It was set up as a straight head-to-head fight. And look, the design of this study is why its results carry so much weight. This is crucial for your exam answer. This wasn't some little study from one hospital. No, this was a big one. A multi-center RCT across 27 hospitals all over the UK. And here's the key thing to remember, the really crucial inclusion criterion. Every patient in the trial had to be considered suitable for both procedures. That's a point you absolutely have to make. So in the end, they managed to randomize 452 patients. And that number, 452, is important. It means the trial had enough statistical power to give us a real, meaningful answer. So, what were they actually comparing? This is a point you've got to be super clear on for your Viva. And here it is. The trial didn't just compare one procedure against another. It compared two whole strategies. Patients got randomized to either a surgery first plan or an angioplasty first plan. What does that mean? Well, it means that was the first thing you tried. And if it didn't work, you could then try something else, maybe even cross over to the other treatment. This is brilliant because it's exactly what happens in the real world. Okay, so how did they measure who won? They used the primary endpoint of amputation-free survival, or AFS. And this is such a powerful, patient-focused outcome. It's not just about, is the vessel patent? No. It asks the two questions that really, truly matter to the patient. Am I still alive, and do I still have my leg? It's a fantastic combined endpoint. All right, let's get to the good stuff, the results. This is the data that literally changed how we practice. Okay, first up, the initial hit. The surgery-first strategy, it came with way higher 30-day morbidity. We're talking 57% versus just 41% for angioplasty. So that basically confirmed what we all kind of suspected. Open surgery is a bigger physiological hit right out of the gate, with more complications. And no surprise, this hit the wallet too. Hospital costs in that first year were about a third higher for the surgery group, and that was mostly because of longer hospital stays and more time in high dependency or ICU. But what about the big one, the primary endpoint, amputation-free survival? Well, the headline news was a draw. There was no statistically significant difference in AFS between the two strategies.
At 3 years, it was pretty much 50-50 in both groups. About half the patients were alive with their leg. So, on the face of it, it looked like there was no winner.
Ah, but here's where the real magic is. This is the nuance that separates a trainee answer from a consultant answer. The investigators did a post hoc analysis, meaning they looked at the data after the trial was done, and they found something really interesting. For the patients who made it past the 2-year mark with their leg, the surgery-first group started to pull ahead. They had significantly better amputation-free survival from that point on. So what does that tell us? It suggests that if you're fit enough to weather that initial surgical storm, the long-term benefit, that durability, is real. Okay, so how do we wrap all this up? In any good Viva, you can't just state the results. You've got to talk about the limitations and what it all means for our daily practice. You've got to mention 2 key limitations. First, that long-term win for surgery, remember, that was a post hoc finding. It wasn't planned from the start. So we have to be a little bit careful about how much we read into it. And second, remember who was in this trial. Only patients suitable for both treatments. The authors themselves called this the tip of the iceberg. Most patients we see are often only suitable for one option, if any. So the trial really gave us 2 big clinical takeaways. First, think about your frail patient, the one with lots of other medical problems, maybe a limited life expectancy. For that patient, does it make sense to put them through a huge operation with all its upfront risk and cost if they might not even be around to see the long-term benefits? Of course not. For them, angioplasty first is the clear, logical choice. But flip that around for your fitter patient. For someone who's otherwise well and you expect to live for many years, while taking that initial surgical hit to get that fantastic long-term durability, that's a trade-off that makes a lot of sense. And that really is the legacy of BASIL. It killed the one-size-fits-all approach and forced us to start individualizing treatment for each patient. Okay, moment of truth. The examiner leans forward, looks you in the eye, and says, "Tell me about the BASIL 1 trial." How do you boil all of this down into a killer, structured answer? Here it is, your 5-point Viva plan. Number 1, the question. BASIL was a trial that compared a surgery-first strategy against an angioplasty-first strategy for patients with severe limb ischemia. Number 2, the design. It was a big, multi-center UK randomized controlled trial with 452 patients who were all deemed suitable for either treatment. 3, the endpoint. The primary endpoint was that brilliant combined outcome, amputation-free survival. 4, the results. The headline was no overall difference in amputation-free survival, but surgery had a higher initial cost and morbidity while showing better long-term durability in a post-hoc analysis of patients who survived beyond 2 years. And 5, the conclusion. The big takeaway is that BASIL taught us to individualize our treatment, basing the decision on the patient's fitness and their life expectancy. And to put a final perfect bow on it, if asked in the exam, the safe consultant answer would be that BASIL 1 showed no overall difference in amputation-free survival. However, its nuanced findings are what truly guide our practice today. They tell us to individualize treatment. We should offer an angioplasty-first approach for frail patients and a surgery-first approach for fitter patients who are likely to live long enough to benefit from its superior long-term durability. And that is how you nail that question.